Thank you very much. It's great to be here with you. And today we want to learn from you, and that's noted in the handout, that we're interested in listening to your feedback about what the local health departments need as far as data from the state health department. We know that it's been a struggle for IDPH putting out data sets for all of you to use on a routine and timely basis, and we are working to do that better. So, like I said, we are very interested in your views, things that you most would like to see from us. So today, I'm going to be talking mostly about the vital records data that is certainly one of the larger data sets at the agency, and one that we do a lot of data use agreements about with various researchers, other parties. But we do certain reports for local health departments, and I don't know how frequently they're advertised that these are actually something that you guys can access. I think it's been a long time, maybe 10 years, since it was really kind of vetted that, hey, this is out there, if you need this, or if this is useful to you, contact us and we can arrange to get these data to you. So we do local health department death reports. We do these quarterly, and then we do annually when we're closing our file for any calendar year. We do. These are crystal reports. Right now we have 55 county health departments and 2 other local health departments that are receiving these. Has details about where people have died, place of residence, cause, details about the cause, and this is aggregated data, but you might see, nephritis, nephrotic syndrome and nephrosis, suicide, homicide, firearms deaths, by place. This is all summarized by place. Flu, pneumonia, emphysema for respiratory illnesses, cardiovascular. So there's kind of the main categories there listed down here of what types of the major categories, but then underneath those I was identifying some of these other things like suicide, homicide, emphysema, sepsis, septicemia, different kinds of cancers, Alzheimer's disease. So like I said, that is done quarterly, and we have 55 current health departments that receive these, and two other local health departments, 55 county health departments. So I don't know how many of you are aware of those, or maybe even get those, but clearly there's a lot that, about half that are not. On the birth side, we are just now preparing to disseminate these birth reports that are similar crystal report type format, summary of aggregated data, show the place of delivery, hospital deliveries, non-hospital deliveries, and then by the different towns. And then we have ethnicity data, which would include Hispanic, Cuban, Mexican, Puerto Rican as particular ethnicities, and then by place, of course, sex, and then age of the mother. Birth weight of children summarized by town again. And these are just now being, we're just preparing to start disseminating these. Hopefully that sounds like something you could use. If it's useful to you, if there's something that you think is missing here, that's what we'd be glad to know. Yeah.
Are we going to be able to where can we access this? In the old days, they used to send us some files and things. Is this something that we'll be able to go out and pull and grab down?
I think we send them as files, as PDF files. Now, if that's not the way that you want them, then that's just how it's been done in the past, and we're happy to change it.
I think that we probably, if we want to do any manipulation or tabulation or charts or graphs or tables, we need it in its raw form rather than in the PDF.
Yeah. in its raw form, even like Excel or something?
Excel, flat file.
Yeah, yeah. Okay, that's good. That makes sense. And that's a good time for us to hear this, because like I said, we're waiting to roll those out, and that shouldn't be too difficult to format them that way instead of the PDFs that I believe we do for the death data now. Then speaking about the details, we do have death master files, which we can share with local health departments. Right now there's 15 county health departments and 3 other local health departments that get these files on a periodic basis. These are only done annually, but it's really all the details from the death worksheet, demographics, the mother-father details of the decedent, whether the death occurred out of state, and then all of the immediate and contributing causes of death with the ICD-10 codes assigned through the MyCar, Super MyCar process, all in the file. Those would be very large, flat files. We ship them securely with this Move It feature, maybe some of you are familiar with. It's a very, very large flat file, and the details from the death worksheet. I think it must be close to the same group that get the birth master file annually. All the details from the birth worksheet that we can share. Some of you may be familiar with a court decision that led to some rulemaking that some of the data in the birth worksheet is withheld. That was Doe versus Lumpkin from like the early 90s. So we have a challenge there, but otherwise, pretty much everything else that is collected for birth record, all the ethnicity data, race data, mother, father, some of the details about the child at birth will be available. And these are shipped out as a flat file, like I said, so that's, I think, yeah.
Question, there was a time when you actually, these same files, created match birth death files. Are those, is that done by IDPH anymore?
Match files?
Yeah, where you will match a birth with the infant's death. It's a little bit delayed, obviously, because you have to close out the year. But yeah, we're one of those 15 counties that receive these death files and birth files. Do you do the match birth death any longer and send those out longer?
I don't believe so. I haven't seen those.
We're trying to figure out, those births that do not survive. How can we look at those infant deaths when we get the death file? We want to backtrack it to characteristics of the birth file so that our group that's trying to look at that, our partners, can see what types of things that were underlying the cause of death.
Mm-hmm.
And I know the CDC Wonder does, they have a match birth where we send them their information, but it doesn't get down to the sub-county level that we find so valuable about this data that you give us for births and deaths. So if you have any suggestions for how we can link those?
Are you talking specifically about infant mortality then?
Yes.
So up to what age?
Up to 1 year of age.
Okay.
So we do look at that, but I don't think we compile any kind of data set out of that.
There was a time when you actually created those, and it was a third data set, so it was all of the infants that died, and that died in a given year, and you had birth information, so you had both of those characteristics.
That may be somewhere else, like outside of our records.
That would be IT.
I don't know. We'll have to look for that.
Okay,
We'll have to look
that's
at
just
that.
one of the, where are you at in terms of the 2017 payment? Is that due out sometime soon? I think we last received 2016 payment.
Right. We just finished 2016, and we were hoping to be able to close a year on the birth and death side within 6 months after the end of the calendar year. It's going to be a challenge. There's a lot of cleanup that we have to do now, the way this is set up. The vital staff and some of Heidi's staff have to work to glean out some of the problems, and a lot of it is, what I find is we hold up finalizing it for like 100 final records. You know, it's like all this is waiting for the last 100 to be cleaned up. And I don't know if that's the best way to do that.
Sometimes there's a notation like audits and things that's provisional.
Yeah.
Because,
Right.
again, when you look at the total number of births, you know, it's, you know, correction factor, you know, we live with that statistical variance in, you know, significance all the time. So I just feel like holding it up for 100, you know, I'm not sure it's 100 records, but holding it up for what would be statistically insignificant, maybe you can say this is provisional data and then final being released, so that if we were to do any analysis of it or report out on something, we would also then be required to say that this was provisional.
Yeah, that's an excellent point, and we should look to do that with these instead of waiting and waiting.
Even if you could asterisk those counties that have provisional data. I mean, if there's 100 sets that still need to be cleaned up or whatever you do with it, you could put an asterisk by those counties that this is provisional.
If we know, I think sometimes on the death side, it's a little, we wouldn't necessarily know, or we may be able to tell by the blank field. Well, I think we can certainly look at shipping something out sooner. I don't know about by being able to asterisk by county. That might be going a little farther than we have the capability.
But I think that just, if the whole thing was provisional,
I think we can look at that.
That's fine.
And just,
A note of, for the, if we were going to send out provisional files, there still would likely be somewhat of a delay because for the first 6 months or so of the year, 4 to 6 months, we see in the death records, when you're looking at cause of death, a large increase, and then it kind of flattens out up until we finalize the record, the whole file. So best case scenario would be 4 months after the end of the year. Possibly 6 months if you want something a little more reliable, and then there's going to be some change between that and the final file. But I think it's, if Vital Records is willing to do it, I can't speak for them, but
yeah, I think 4 months is still a lot better than where we are today.
Yeah.
And then the birth should certainly be available sooner than that. So, very good. I think, you know, the previous leadership and management wasn't comfortable putting out the provisional type of records, but I think today people kind of are ready for that. Understanding that, hey, there's some things we can't account for, and it's going to be that way. So, thank you for the suggestion there, and that's something I will take back to Vital Records and see if we can push those through and get some 2017 data to you guys. Now, so right now, we've only got the 15 on each side, which I know is your one of the 15, right? So, hopefully, if other counties are here and would like to access this, you can get in touch with me. I think you got my name and contact information either here or in the packets. Something else that we do that probably is, it's another summary type of report, and just so you guys know, since it goes to your colleagues in the local levels, local registrars and county clerks twice a year get tallies of births and deaths by their jurisdiction. It does include, you know, people that are in the area from other parts of the country or from out of the country if they have a vital event that's summarized in the report. That's the manner of death is summarized there, whether it's an accident, homicide, natural or suicide. Disposition of the remains is summarized, and we've got our ethnicity and race information as well. Those are done twice a year, and I don't know how useful this might be for any of you, but just to let you know that it's there, so that if it is something you'd like to see, you could either talk to your local person that receives these currently, or let us know, and we're happy to share them. We're already producing them. And one of the newer data sets that we're bringing out is the syndromic surveillance data, which is nice when we talk about real-time data. This is as close to real-time as I think we have at IDPH. This is from hospital emergency departments. It's used for surveillance. We use it for flu, opioid, rabies, and then any type of events like the big eclipse event, just monitoring to see if there was any types of surge activity related to that kind of event that need some attention or some investigation. The software that produces this kind of, I'll just show you the next slide is what it looks like. It's Windows-based, visual. I haven't used it, but I'm told that it's very easy to use, and there's technical assistance. You've used it? So it uses Essence in the CDC's BioSense platform. One of the nice things I thought was that you can view hospital visits in the jurisdiction, regardless of the patient's location, or you can see patients that reside in your jurisdiction, regardless of which Illinois hospital they would happen to visit. These dashboards can be set up by any users, and we do have staff at DPH that uses this quite frequently, and they can help either set up a dashboard that can be shared, or people in your offices could create dashboards and share them with other users in your office.
Bill?
Yeah.
I have a question about the hospital data. Does that include hospitalizations for Illinois residents that are seen in Missouri for our county? We have a lot of our residents that go over to St. Louis, or is it just IHA or the Hospital Association reporting data that gets down to you guys?
It's from the Illinois hospitals, and I don't think it yet has reached that level. I think we're looking to CDC for more accessibility for that type of out-of-state occurrence, which is very important.
We're in the bi-state, and our Missouri partners use Essence as well, so at least for emergency response stuff, our EPIs all talk to each other with hospital-based data through Essence. I don't know if they're using their own separate Essence than what we're reporting to you, but I would hope that some of that at least is being shared. Like, I know that some of the emergency response meetings I sit in and the EPIs are talking, they'll note if it was something that was noted where they got treated versus where their residence was. So, I don't know, I just assume what they're doing if they're talking about it. But it's my understanding that some of that, because that Essence platform for us was built kind of across the, like our EPI at our department on our side of the river, I know can share and talk with the ones in the St. Louis health departments, with at least emergency response-based data through Essence.
So our contact person may know how to do that.
And you know her right now.
That's Stacey Hopper. Okay. I was going to see if we can get an answer now if she's at her desk. That was a good question. I didn't think of that. Coming in here, being from Springfield and right here in the center, that sometimes doesn't come right to my mind. So at the bottom here, like I said, that's she's with a different office. I put her contact in there. She'd be happy to work with you on setting up something that will be useful to you. And I believe that we're going to be seeing more, that we're going to be advertising and promoting this more in the coming months. So glad to share a little bit about that today. That's just a basic, I just wanted to give a picture of what it looks like. Like I said, I've never used it, but time series mapping. And down here is, I think, the overdose data list. Okay. That completes my section for now. Okay, yeah. I wanted to ask, as we were talking here before the session, how many of you are familiar with the hospital report card? Or can you use that? How many are familiar with it? Okay. A couple, how many use it? Okay. Very good. And then we have the public health community map, also on the IDPH website, which has different measures. Familiar with that? No? Yeah. So that's good for us to know, because we're not getting that out. So maybe I'll try and send that, something about that around if I can, through the forum here or through some of the associations. We spend, a lot of time developing those websites, and then we don't spend a lot of time promoting them and letting people know they're there. So that was good feedback for me to have.
Also related to that, Bill and I work on the state health improvement plan, and one of the objectives out of, I don't know how many, but one of them is to produce a list of data resources and put them on the IDPH site, which hasn't happened yet, but our goal is to have one up on our site by the end of June. So it'll have links to things like the public health community map, to iQuery, which Nelson will talk about, to our opioid data dashboard, which I didn't put a slide in about, which was my fault. It's a new data resource. If you haven't seen it and you want to look at county level data, it is really, really helpful. It has information from 2013 through 2017 on it. Death data, hospitalization, and ED discharge. The website for that is idph.illinois.gov/opioid data dashboard. Our normal website is dph.illinois.gov, but if you do that, it doesn't work. So do idph.illinois.gov/opioid data dashboard. The landing page, you see three different maps. You can click on your county or even down to the zip code level. I live in a pretty rural county. I live in Schuyler County. I'm new to Illinois, so anytime I look at a map, I look and see what data is available for Schuyler County. It's usually not there. So if you're from a rural area, I feel your pain. But when you're looking at the zip code, it gets a little more complicated. So there's a lot of blank spots in the zip code map. However, the county map does have data for all counties. So I'm only going to be up here for a minute talking about the behavioral risk factor surveillance system. I'm assuming most of you are probably familiar with this. In Illinois, we do the state level survey annually and the county level survey on a rotating basis. Ideally, it's every 3 years. Doesn't always happen that way. Right now, they're completing round 6 of the county survey, so it should be completed by the end, before the end of this year. However, the data won't be out on the county level for round 6 until next year. 2017 statewide data will be available towards the end of 2018, target date sometime in September. So keep your eye out for that. And also related to the BRFSS, we have a lot of data on our end and some ability to analyze it. We need to hear back from anyone who uses it. What's most helpful? What kind of reports are going to help you? We can guess what you need, but you guys are the experts in what you need. So if you just provide feedback, I believe there's a link on the BRFSS page, which is there, idph.state.il.s/BRFSS. At some point, we are hoping to put the BRFSS data into iQuery, which Nelson will talk about next. But for now, that's where the data reside. I don't really have much else to say about BRFSS. Do you have any questions about it? Mm-hmm.
Yeah, kind of even use that website as well. But whatever we can, I know that there's probably concern about manipulation of data, but oftentimes it's in a PDF report. So if I want to do an pie charting or anything like that, or even a trend analysis in my own opinion, I have to go and manually enter it all. So of course, then I'm always worried about fat finger entry and did I. But, I mean, that's the kind of stuff that really from locals now, it's not, you really need the ability for more dynamic reporting than just static report. And that's what I think. And I understand that there would probably be some, we have to make sure that, we sign every day a special login, or if we're going to manipulate the data or something that, we wouldn't upload incorrect data back to you in any way, shape, or form. But I think from a local administrator, even looking locally with my epidemiologist, it's very difficult because they're having to it's very widely stuff,
Yeah.
but it's not going to use the point.
I hear you, and that's something that we're definitely pursuing. There are some technical hurdles that we have to get over, but there's a big push within the department to move towards that. Yep.
I think, you know, in the past, we've had the ability to pick from a few extra questions to add to the survey.
Yep.
But those are pretty standardized questions. I think it would be really good if we were allowed to create questions that we really want to know about our community that maybe won't be on that pick list.
Mm-hmm.
So I think in the future, it would benefit us if we could do that.
Yeah, if you, when we're working on the county level surveys, which like it's about every 3 years, plus or minus, when we do that, we have reached out in the past, you know, with the list. Gail Blair has been working on that. You might be familiar with her. She's retiring. So it's me and Roland now. So I hear you. And I think when we send out for feedback in the future, we can include that as an option, the list of standard questions and then suggestions. The only thing about the suggestions is once we get those, we'll probably have to send it out again to, you know, it might work for Schuyler County, wouldn't work for Sangamon, and we'd want to make sure that it all works for everyone if we're putting it on a statewide county level survey.
If we have some specific programs out there that we might want to collect data on that and see how it's impacting people and their health, that might not be on the standard lists.
You mean like if you wanted to do just something for your county only?
Yeah.
We could definitely look into that. We'd have to work through some technical issues, but we can look into it for sure. All right, Nelson, you want to talk about Agbodo? And after Nelson's done, I'm just going to throw this out here. We want to hear more from you about what you mean. You should have all your signs. It does one side.
Okay, so I don't know if I need to go to the basics of iQuery. How many people know about iQuery? Oh, well, so there's no need to go to the basics. Actually, my presentation have some basics, but I'll go quickly over this so we can get to the technical aspect of it. So as you know, it's a web-based data query system, and the goal really is to disseminate public health data. To get public health data at the record level, it's so difficult, as you know. So iQuery actually help with that by providing the data at aggregator level, which will help with need assessments. And how to get to iQuery. The reason I put this up is that we realize that people still go to iPlan website and use iPlan data for local need assessments. Actually, iQuery is supposed to replace the data aspect in iPlan. So if you are using data for any health assessment, health need assessment will be actually iQuery data. And you can access the iQuery through iQuery website or go through the DPH website. And also, if you go actually now to the iPlan data section, you click on iPlan data system, you will be directed to you'll be directed to iQuery. And there's 3 levels of access that we give. System administrator, of course, that's what I do. And data manager, if you have data to share through iQuery, we will provide ID and password and give you the access to the back end to share data and also the public access. So actually I have this to show the public interface. So as you are using this, you already know the interface. But the indicators are organized in 3 levels. So we have the actual indicators and grouped into categories, and then the categories also are grouped into topics. So data managers have their own topics where they publish their indicators. So I give this example of BEF and DEF data where you can go to the categories. You have infant BEF weight, and then from there you select in the third box the indicators. Here we have a selection on the BEF weight between 1500 and 24 milligrams. So that's kind of a low BEF weight indicator. And then you can select indicator at a geography level. For example, for this indicator we have county and state level. So you can select any county or just multiple county as well. Here you have multiple options. Then the next level of selection is the year. So as of now, we have this indicator to 2016. That's the latest we have from the state enterprise data warehouse. And then you can also do a final selection at the demographics level. And then you have the indicator. And here it gives you the count, and you also have a percentage with the total number of low BEF weight over number of BEF for each year. So we are working with the supercomputer group at UIUC to develop alternative health profiles. And this is going to be in a new system. And we are hoping that this system will be superior to iQuery. So it will do what iQuery is doing right now and do more, because we believe that iQuery needs to be revamped to give more information and more flexibility as well for publishing data. If you are familiar with the back end of iQuery, and if you are data manager of iQuery, you know that only 3 types of formats are accepted by iQuery. But today with a big data thinking, powerful statistical analysis, we cannot limit ourselves to that. So we want to do more with the system we have to disseminate our health data. So we are actually selecting the indicator for the county health profile, and the indicator actually really align with the Healthy People 2020 objectives. But we also, I received some of feedback from my survey. I think that there was a survey of the iQuery users about new indicator that they want to see in the system. So we're adding those, and like Bill said, we're here really to hear from you to see what else we can add to better serve you. So I will now open up to questions or discussions. Yes.
I have a quick question on the new county health profile project. Is it going to just be the same kind of data that goes into iQuery, or will, since it said by jurisdiction, will the jurisdictions also be able to upload data? For instance, through we have a partnership for drug-free communities. So we've grown it from our county to, we're trying to make it more regional, and like us in St. Clair County are now getting data from our EMS and from our hospitals, real-time data specific to opioids, because that's what our groups are really focused on right now, but it has potential to grow. Is that something that if the people that provide the data, our coroner's office gives us data, that we'll be able to upload into that system with permission from the data suppliers, or is it just going to be what IDPH and UIC is putting into the system?
Well, thank you for the question. This new system will operate at 2 levels. The first one, to be able to visualize any data that is in the system, just visualizing statistics. We'll be able to do cross tables, things like that. But the second level is the health profile. the county health profiles, and it's going to be kind of a static profile that you can print out. So as of today, we have selected 40 indicators. Like I said, those indicators align with Healthy People 2020 objectives, and some of them the indicator that we previously had in our I-plan was selected, and we received some feedback from the counties that we are using that for the selection. Well, like you said, and opioids, of course, will be one of the indicators that will be in the profile, but the list is not yet closed. So if you have a specific need, I can provide work with you and see how we can incorporate that. But really, today it's very open in our list, so we can have more and more discussion on how to make it work better for.
So if it's an indicator that we're looking for, we can give you a suggestion of indicators still, because that ends open, but it's going to still be a push system from the state perspective, not also a pull system from the local data that might be available, right? It's okay either way. I'm just trying to understand how it's going to work.
Yes, that's exactly what I'm thinking. The incoming data from external providers might not directly fit the profiles. We had to work on that, because actually in the system we actually setting up the format for the data that will fit these profiles. So if we know ahead of time what kind of data or the indicator that we need to add to the profile, we can work on the data profile, even if it's coming from outside to fit the indicator. I don't know if that answers your question.
You answered my question, so it's good.
So we're kind of envisioning this as almost like a pilot project. It's a real project. We want to have it done. Once it's done and we can show that it works, then we might look to expand it. And at that point, that's when we would consider bringing in other data. But until we can get the product to work with the data that we already have control over, it would probably be too big of a hill to climb on this first aspect. But that being said, this is phase one. That's what we're calling it.
So it's going to be more like the county health rankings, but just for Illinois, with our own designated indicators based on the data we already have.
Basically, yeah.
Okay.
Yes, when you say based on the data we already have, I would say we can add more data at this stage. Sure, I mean, so like before, we didn't have opioid data in a high quality, right? But today we are expanding to that kind of data. So we add other data if indicator, some of the new indicators need those kind of data. But like I said, we had to know ahead of time. So yeah, we are in a phase one, like Heidi said, and what will happen in phase one will be the basis, and then we can improve with more discussions.
Is there somewhere even that we could weigh in on what the indicators are, or at least understand what they are?
Or see what they are?
Because I think that probably, I've heard Healthy People 2020 mentioned now and a couple of things, but I know even from the NAS, task force, some data that was being looked at. My concern is that the minute we roll it out, it'll already be kind of outdated for some other indicators. So I think it would be great to have some kind of forward thinking and validate, we're all in agreement that those are the 25 or whatever we're going to be able to pull on, and then kind of thinking with our best efforts and guesses what we might want to be looking at in the next few years.
Yes.
But right now I'm not sure when you say there's Healthy People has thousands of indicators. So I guess it would be helpful to know which ones you're looking at for building the pilots.
Sure. I think we'll figure out a way to communicate that with you. And that's really what I need to do because I know you are going to be the one using those indicators, and we really want that to fit your needs. So yes, we'll do that.
We push it out to our administrator list. So once you're listed as the administrator, you'll get it. If you got my email about a month ago about opioids, then you'll get it.
When you talk about uploading, how do you see that as working? I guess I don't get what your vision.
Well, on the backside, I've been on the iPlan implementation committee for almost 20 years in the state, and we haven't met since Gail and Tom retired. So this would have been something that I think would have been a conversation piece to have through that subcommittee, and we could have talked about some of these issues then. And what I was asking about an upload is just because we are doing this kind of by county, we're going to grow it to more of a regional approach. We have some people from other counties around our two big counties that are helping with different pieces, and we're all just trying to figure out how to make it work right now. Is maybe what we need is a dashboard for our region to do this with, because right now we have someone from our substance abuse agency who covers the counties, who brings statistics to our meetings and shares them with us by hand, because that's the mechanism we have right now. So it would be nice to be able to have some kind of a platform for at least the counties in our region that are working on this particular issue to put the data that we're getting from the coroner's office, from the emergency room departments, from the EMS agencies, from the regional office of education, into a system just for our region, for us to be able to look at and see where some of the hot spots are even in our region, instead of just her having to do it the old-fashioned way and make 50 or 60 handouts at one or two meetings to try to talk through it with people. So that's why I was asking, because I didn't know what the new system was even going to look like, that if there was an opportunity for a portal for just like a region or a jurisdiction. When it said county jurisdiction, that's what made me think of it, was, ooh, we might be able to upload our own local data and what we're using real time, that we can all look at it across the board in an easier fashion than what we're doing, because we're already sharing data and talking about it. It's just in a very archaic way because we don't have a mechanism. Does that make sense?
Yeah.
So it sounds like this system is not being designed for that at all, but it would be nice to have some kind of even a generic dashboard on a separate platform even developed that the local counties or regions of counties could utilize for whatever kind of data that they are getting locally that they wanted to input and share with each other for conversation and planning. I mean, that all goes back to what we discussed in the first session, and that's being innovative and thinking about what do you really need, where are we at now, what do we need, what would be helpful. So maybe a dashboard of some kind could be your next pilot project that then the locals could use. And
there's a lot of tools out there which we're putting together this list of tools. One thing we want to be careful is not doing something that is identical to what somebody else has already done, which is kind of where I feel we fall into the hospital report card now, that it was a great idea in 2006 and we built it. Now, there's lots of other places to get this information. You didn't think it was a great idea then? Okay. Well, it was done in 2006. Maybe that data wasn't able to see how care was delivered. But now I think there's more out there. Medicare is now pushing out data. So that one, unfortunately, is statutory mandate, so we can't just stop doing it without we'll keep your idea in mind as we look to these other resources that we have. Maybe there's something similar that we can find.
if you run across something like that, can you just email it to us? And
Yeah,
get it?
absolutely. That would be.
You don't have to pay for it in advance. If you see it or know it, please send it to me or Mark. We'd love to see it.
Absolutely.
I think what we're starting to hear is more and more we're manipulating data at the local level report. And I think the challenge for us is on what data sets and variables are out there and where it's available from.
Right? So, I remember the days running Foxfire reports out of Cornerstone. We could determine which data, not every field was available for a data select. But again, understanding where that might be, that kind of data dictionary piece. Like, where does that data come from, and could it be pulled in a set? Rather than, I think what we're trying to say is not forcing out a report. So I could pull by zip code or county code. So if I'm doing a regional approach or I'm looking at something else and I want to know substance abuse admissions or something, we actually did some work on essence regarding the synthetic cannabinoids and bleeding. Now, very few people come to the hospital for marijuana, but just in case they decided to get hospitalized for it. But I think that that's the kind of stuff we're having to, because we have to really kind of be more nimble and move through it. So whatever working you can do, rather than maybe canned reports, might be kind of what where's the data pulling, what data sets can we get access to, what variable data could we get? And then allowing us to pull it down, and then, you know, depending on the size of the county, you might be able to do it by hand, you might be able to do it by Excel, you need SPSS or SAS or something, the larger the county. Because again, I feel like you're trying to help create reports for us, and we're like, well, some days I need it like this, and some days I need it like that. That's really, because the hospital report, it started over there, and then it kind of moved over to that. And I think that that's hard for any of us in this day and age to, you know, kind of define these, or how it's always going to look. The report cards you see from the kids now don't really look the same from when, like a couple of years ago. So I think that that's what we're trying to say, is whatever you can do to advocate for that would be probably more use of time and figure out, you know, is it something enough? Because I think that's the beauty by query, right? At least the theory was I could pick what I wanted to look at, right? And it would run it for me and I could download it. And rather than pushing out a PDF report, you know, to me.
And just a note, until we're able to develop those data resources, you're always welcome to reach out to us. We can email spreadsheets a lot easier than we can post them on our website.
To just go on with hers, if there's any way, since the pilot, you said it's not quite done yet, if you could search not just by indicator, like one of the limitations I think of iQuery is you kind of start with the indicator. If you could do it by, I don't know, I get all kinds of weird calls at the health department every week, I'm sure everybody else does. Can you tell me what diabetes is in this community, in your community, with this particular population of whatever, African American women who are under 60? I don't know. I don't even, you know what I mean? Like, if you could have some other way to shuffle the data, or like, maybe she gets a call about what's going on with substance abuse in general in this jurisdiction. If she could click on substance abuse and click on the zip code, and any data indicator that you have that's tied to substance abuse in that zip code in that database could pop up, then the user could choose from there what, oh yeah, I need that, I need that, I don't need that one, I'm gonna open this one, I'm gonna open this one. That'd be a lot more user friendly for that kind of how do we need it each day. Because it's not always by the indicator that we need it. Sometimes it might be by the population. Somebody might say, county board member, what's really going on with youth in these 3 communities in your county? Health-wise, what kind of data can you pull? Click on youth, put in those 3 zip codes. What do we even have access to? It's not giving us the full picture, but it could be at least through this database, this is what we're able to find. So I don't know if you can do that yet. I don't know how far you are in the setup, but that might be helpful.
Yeah, that can be possible for some of the data, because some of the data we receive from data managers are not at that low levels. Most of the data at county level is possible, but when you go down, lower than county level, because of data confidentiality issue, things like that, you don't really see anything. So if the data at lower level is possible, yeah, I think we'll be able to do that. Like this new system, like I said, we'll have 2 sections. One is for displaying data, but so far we are actually doing that at county level. But the other section is to produce a static report, so our county can be compared on the same indicators and compared to the states. So in the visualization aspect section, you can pick what you want and visualize that. But we are actually limiting everything at a county level. So we can have more discussion about if we can go to, I mean Chicago, it's always like, on another geography level, we can go to Chicago at that point. But if we are going to the zip code, we have to know what kind of data it is. Like, for example, HIV data. If you go to zip code level, you might get in trouble with confidentiality issue.
I'm not as worried about the zip code level as I am the ability
I know
to
it's an
search
example.
by different types of, by audience, by geographic area, by indicator, by whatever, than just straight.
Okay.
I mean, I know that once you pick an indicator now, you can drill it down, but you kind of have to start with the indicator.
Great input, thank you.
And related to that, I think so that we can get more of your feedback and feedback from some of your colleagues who might be in one of the other sessions, I'll send out an email to everyone about the project, the status of it, and then we can schedule a call. I plan implementations committee call, maybe rename that. Data needs call, and then we can, anyone who wants to call in and give more feedback, or if you just want to write back to me or say like this sounds like a stupid project, whatever, that's fine.
Who will
Just
that
be
go
honest.
out to?
All the administrators, as long as you're on my list.
I didn't suggest everything that you put up there would be a good idea of what's available.
Okay.
So I've seen it, but I forgot about a few pieces.
Yeah. Very good. Well, good. I'm glad that, you know, that we're bringing today. And this project that Nelson's talking about is a new relationship we have with the U of I Urbana-Champaign. And, you know, we're hoping that we'll be able to continue working with them because they have a lot of expertise that's different than what we have, right, with computer development and the hardware that they have. That, and I was also going to mention the county BRFSS. These are projects that we undertake because we have the block grant funding, the HHS block grant dollars from the feds. That's part of what we use those monies for. So just want to point that out to you as we move ahead to more federal budget discussions. That those are the types of things that we're using the block grant monies for here in Illinois. Yeah.
For the data resource list you mentioned, I wasn't clear, is that just going to be a list of resources through IDPH, or it's a broad list of different?
The idea is it's more broad and it's a working list. So right now, we have the beginnings of a list. It has DPH data, it has other state agency data sources, and then there's some federal and non-governmental sources. It is by no means complete, so I'm looking for any feedback on it, any resources that you're aware of, especially as you do your needs assessments. You're going to know more about data, especially those of you who've been working in public health sector for longer than I have.
Yeah, I think this group would be able to crowdsource a lot of really good data resources, and then everyone would benefit from hearing about a new one, because I feel like I hear about a new one every once in a while, and I think I kind of knew all of them, so they're popping up as someone mentioned, and it'd be great to have that.
Yep.
Heidi, could you give that website for the 2013, 2017?
The opioid data? Yeah, it's idph.illinois.gov/opioid data dashboard.
I think it's on our landing page now.
Yeah, also if you go to dph.illinois.gov, it's on the landing page. If you
The
can
button
find
at the
it.
bottom. It's just a button at the bottom. There's some main buttons.
What's the opioid data dashboard?
Yeah, idph.illinois.gov.
Oh, there we go.
Yeah, even if you
Let's
Google
go to DPH.
IDPH opioid,
Let's go to- yeah. Well, that's right. So we just do that.
Okay.
DPH.
So I did, okay.
DPH.
IDPH, I don't know if this is actually connected to
Try
the
DPH.
internet. Okay, it is? Okay. IDPH opioid data dashboard. You can probably get it from here, right?
see, yeah.
Yeah, there it is.
One thing I just want to do a little caveat of this, it can run a little slow, but the data does load. So if you click on a county and it's not loading, just go and do something else for a little bit and come back. I can click through, I won't have my button.
Have you watched the video?
Really? That dashboard tutorial?
Yeah.
Here's this.
I just wondered if you'd seen it.
I don't know if this is connected to sound.
Probably not.
So there's a tutorial video, what is it, 4 minutes?
Yeah, it's 4 minutes long. They talk you through how to go through it. You can see it here, there's 4 tabs: mortality and morbidity, trends, prescription opioids, and mortality details. If you go down into, I'm most familiar with fatalities, so I'm just going to click in one of those counties. Let's go with LaSalle. We don't have an asterisk. The asterisk means there's less than 10 cases, which is good, but you won't be able to see the numbers. So if you click on that, that's where sometimes it can, oh no, it's not working. It works, I promise. Well, when you click on it and you're sitting and no one else is watching you, then it'll go into the next page, which is trends. I'll just click on it, it'll show you statewide rather than county, but it essentially looks the same. You'll have 2013, this is where you'll be able to see 2013 to 2017. No, it's just slow. Seems like that. But I did mention that it was slow, so it's hitting my expectations. We also have some statewide data if you're interested. Some of the other data that we have in our division is the Pregnancy Risk Assessment Monitoring System, or PRAMS. Unfortunately, it's not weighted to a county level, but you can look at it at the state level. We have population estimates. The state demographer works in the division, and also the state vital statistician. So if you have very specific requests, you're interested in, I don't know, a specific cause of death in 1997, you can reach out to him and he'll be able, or reach out to me and I'll put you in contact with him, and he's able to pull reports like that. I'm going to blame this on the internet here, because it's not normally this slow. It takes a couple seconds. But I want to say there's 5 or 6 small little graphs on there that shows heroin and non-heroin opioids, death, hospitalization, and ED discharge, then broken down by age, sex, and race, I believe.
Is it breaking out fentanyl?
It does not break out fentanyl specifically. There's no way to break out fentanyl without searching literal codes in the death certificate. So right now, when death certificates are submitted, they're run through the MCHS SuperMyCar software, and they're assigned ICD-10 codes. The lowest level that they get in the ICD-10 codes for that is synthetic opioids. So this does not have synthetic opioids at the county level. We're always working on improving this. I'm not as familiar with the hospitalization ER discharge, so I know they generally do other opioids, meaning non-heroin. We are working on producing more data at using those literal codes. We had a brilliant intern who's no longer with us who wrote a really good code in R. You can run all of the overdose deaths through it, and it will tell you how many of each type of drug is in there. I'm not as familiar with R. I have it, and I'm working on learning how to do it. So once I know how to do it, I can push it out. But right now, it's as far as we get down to on our monthly data report. There's one other thing I can mention. It's the same information basically that's on the dashboard, but we do have a data report that's produced monthly that has annual data on it. The most current data is 2017, and it's just opioid overdose deaths, and that is a required report under House Bill 1, Heroin Crisis Act. That's what I have to say about it. Does anyone have any, do you want to tell us more about your data needs? I'm going to sit down. You want to say? Can I take it? Just talk.
Okay, well, I thought about, we could go back, do you want to go back to the internet? We could bring up this public health community map.
Ask them how to respond.
If the internet is working, it
It's
really
working,
didn't seem
yeah.
to be.
It didn't seem to be.
I'll close this up and see if it'll
Well,
work.
it did bring up the dashboard page, which you probably haven't known. So I know there's data on there about asthma, behavioral health, diabetes, preventable hospitalizations, and there's also income and social determinants type data. It's been a while since I've looked at it. I really never have spent a whole lot of time on it, browsing it, unfortunately. But we do spend a lot of time and energy putting this together. And since it wasn't something you guys are familiar with, I think it'd be worth throwing up there. Okay, there we go. So hit view the map there on the left. Yeah, that's just kind of the title page, and it's got some resources there about how to use it. Okay, so that one came up pretty quick. So again, this is, the measures are predetermined, so it's not so much you can make your own, but there are different measures that you can select there, and they do go to the county level. So if you were to hover on a county, it will show you, so this is the ED asthma visit rate. And it does go county, and I think in Cook County it might go lower than the county level. You might have to click on it first. And then the category and the measures there, boxes, we might just pop those open just so people can look.
So it breaks it down here for each county.
Yeah, so those are more of just the quick fact information. But I hate these little pads. Here we go. Asthma, pediatric asthma. Because we're on asthma over here, so those are all the asthma measures. Behavioral health was a recently added item. That's our newest one there. Cardiovascular disease. There's some of the diabetes. Diabetes prevalence. What was your county? That's a big one here. Christian County, 1.9%. And then it just gives the demographics. So if you have feedback on this, we'd love to hear it, because, like I said, we're spending time and money on this. If it's not valuable, if it can be improved, we'd love to hear from you how to do that.
What years does this cover?
Right now, it looks like 12/31/2014 is the latest for this particular one. That's always a challenge for us, is getting, the latest and greatest data that we have available. A lot of this is sourced from our hospital discharge database, which is another one of the more popular ones. But we do run a lot of ad hoc reports, and that's the one thing, we're happy to do them, but because, when we're doing those, we can't do things that are more ready for everyone. So it's a trade-off. Yep.
So I'm not a public health person. I work in law enforcement. So coming from that first talk about partnership and cross-sector collaboration, something that is really helpful for me to encourage my bosses to work with our health department is money. If you guys have a lot of partners at the state level and the local level and with private through hospitals, is there any discussion about trying to at least estimate costs associated with all these indicators that you're posting publicly on these websites?
When you say estimate costs, what do you mean?
I don't really understand.
Well, I'm sure it would be really hard to get the exact cost of everyone who has asthma. But if you have hospital discharge information or Medicare, Medicaid information, and you could say in general we think a child that has asthma costs the community X amount, that would go a long way to get built environment folks, for example, to maybe invest in certain things that can help reduce or manage asthma. Whereas if you say there's an increase in 20% of children who have asthma, that's not going to mean anything to the people that I work with. Or it's not as persuasive.
I think that's a really good point. probably have to work on finding partners who are, well, Nelson here.
Like, I'm sure that's going to be a huge undertaking, but in the realm of opioids as well, I mean, in particular, that's going to be something that will help people invest from other sectors and diversify your funding streams.
You might be able to link to any of the CDC modeling and things like that for when they do the estimates for that, like the cost per, you know, because they've just come out with one recently. So I think that would be the other thing, would be any linkage where there is at least an estimator on some of that modeling data.
That is a good point, because that would be that more ready to use information, especially getting to the costs.
But I think also partners come to the table when they already know they're being affected. So we've had no problem getting our state's attorney on board, our sheriff, like those are the guys that started this 5 years ago. They started a heroin task force in our county because the sheriff, the coroner, and the state's attorney all work for the same county government. That's our board of health. And they were like, this is crazy. We've got all these people dying and it's draining resources from our 3 offices. Let's see who else we can get together. Let's call the health department. Let's call community development. Let's call the substance abuse agencies and see, because so that for that particular issue, it's an easy sell because we already feel it hitting our particular industries. So it's been real easy to get people to come to the table because they already know what kind of drain it's putting on their resources. But for something that's more obscure that we know is an issue, an ROI estimate would be helpful to get partners to the table. Like when we did Complete Streets through the We Choose Health grant years ago, fantastic thing. But that took a little more persuasion and having our planning and development department at Madison County take on that part of the project because they already had those established relationships in the municipalities and they understood the cost more that way. And then we had to talk to them about health, but we didn't have an actual price to put on it. But we had data to share with them, and that actually was what helped them, was just seeing the data part was convincing for them. They didn't need to see the dollars, they just needed to see some of the impact. So, but it is helpful with some of them are tricky to get on board.
Or maybe the partnership will just happen faster, less persuasion, you could just say.
But again, I think anytime we can link to modeling data, like for every diabetic, you know, we expect to have, I know that that's always a question, like how many primary care, how many retinal specialists do you need in your community? There are some already, so based on number of diabetics, you know what the population rate is, how many you should have. So when you go and you're doing your assessment about gaps, so whatever, there are modeling, you know, we know the CDC does a lot of that, and there are others that do some kind of like, and I know they've just recently come out with the opioid cost for everyone, like years of lives lost plus total economic impact, you know, per individual who's, you know, hospitalized or who is, you know, dies from an opioid overdose. So, I mean, those are the kinds of things, wherever there's another one we can link to. Because I think, again, you know, if there are, because again, we don't want to go out and have everyone going out there and using unreliable sources of those models. Because then it invalidates our discussions.
Absolutely. If we did a years of life lost, is it disability?
So we had a project on, we actually estimate a disability for the state at county level as well. And we use that data to calculate the potential years of loss. And I don't think we publish that on the IDPH website, but we do have that data and we can share that. And we are looking into doing more on that because, you know, we understand that when it comes to life expectancy, things like that, it's actually easier to communicate both ways. You know, the potential for us, it's very powerful statistics. And so if we're looking at the life expectancy, we should also look at the loss. You know, so you know, either way will work for different projects. So yes, we do have the data, and we can share it.
Well, as you can see at the bottom of this landing page, there's both the hospital report card and the consumer guide to health is related to that. And then the data dashboard there, the opioid data dashboard. said something you think. Oh, go ahead.
So I'm just going to read you this email that we got back from our surveillance system, syndromic surveillance person. She said, I asked, does syndromic surveillance include data from the border states like Missouri if they see an Illinois resident, or is it more facility location focused? She said, well, yes, the national syndromic system that we use includes data from Missouri. The Illinois does not have access to the data at this time. So the Illinois resident went to a Missouri hospital. We can't see it right now. The system allows for sharing to be established between any two jurisdictions, but each state controls data access for facilities in their state. Currently for Illinois, we only have data sharing established with Kentucky in the national system, and it is aggregate, so we don't see the line level. She says, I also have access to Missouri's local system to see some data. So it sounds like it is a data sharing between states issue, which is always an issue.
And when Nelson was talking, I was recalling the dig site, data.illinois.gov. You know, when we talk about pushing out more of the line level details for you guys to manipulate, this may be the platform that we kind of have to fall back on to do it, because you know the greater state of Illinois agencies have set this up, or all the agencies use. We have several sets out there. A lot of it is kind of directory-ish type information rather than what real health data. So we have to manipulate those files to de-identify. But this is something that we're looking at as a way to get more of the line level data that can be exported, manipulated by you guys instead of us producing static types of reports. Any other thoughts, concerns that you have for us? We've got a pretty good to-do list from your suggestions here. So that's been very valuable, I think, for us. I hope that it has been for you today.
And any feedback you ever have, please reach out, because we can only guess if we don't hear from you.
I know Heidi will be here tomorrow. Will you be here? And Nelson will be here tomorrow. Going to try and make it some of the day. The State Board of Health meeting that popped up. That's going to interfere with my attendance tomorrow. But I'll be out here for some of the day.
Great. Any last questions or comments? Otherwise, I'm sure folks will be happy to have 15 minutes or so. For a round of applause, and thank you so much to